and the title, as you see, is replacing the stent or no. We'll see, because the evidence is building quickly and moving towards the drug. Why the drug-coated balloon is on board and now is taking a good support, because no permanent scaffold, thrombosis is less if the lesion is prepared well, and there is no significant dissection, because the dissection may obscure the flow and decrease risk of the, as well as the edge dissection in the stent, which is carries higher risk of stent thrombosis. And on top of that is shorter duration. It will help the patients with high risk for bleeding as well. The mechanism which make the drug-coated balloon is advantageous over the stent is the drug delivery without metal, also the faster endothelial healing, and the potential clinical scenarios favoring the drug-coated balloon. The high-risk bleeding patients, osteal lesions like the circ, because the circ doing bad with the stenting, and the restenosis is high, and the restenosis, if happened with the balloon, is better than happening with the stent itself, because it is very challenging. That's why the preparation is the first successful step in the doing BCI in the osteal lesions in general, in the fizzles in general, and in particular in the osteal lesions, and circ is a specific disease entity. The other cornerstone target for the drug-coated balloon is diffuse long lesion, which makes the drug-coated balloon is favorable. The evidence is growing very fast. Yes, the drug-coated balloon started 2004, but now is gaining more evidence, more support for different parts of the intervention for the de novo lesions, and the large fizzles now is taking some, yes, did not come to the guidelines, but it will, if the evidence is became stronger and stronger, it may attract this attention. CTO also, there is a role for the CTO, for the DCB in CTO. Osteal circumflex is a particular, as we mentioned. Elderly patients with acute coronary syndrome, and the risk of bleeding, risk of compliance with medications, dual antiplatelets is a problem, presence of atrial fibrillation. Those are the scenarios which attract the drug-coated balloon, and the evidence is supporting this slowly. And the different evidence from registry, from around small trials to the moving towards the larger trials, and also the randomized in the future, larger and larger, since the concept proven the safety of the therapy, it's now is going. And in comparison, the drug-coated drug-eluting stent, it is comparable. It's not non-inferior to the stent in multiple stages of the MACE. Different registries compare the DCB with the DS for the larger fizzles, showed the non-inferiority, and with late lumen loss is less with the drug-coated balloon. Yes, revascularization is higher, but probably it refers to the baseline preparation before you implant the stent or deploy the balloon. Also another study with the maybe longer follow-up, up to 3 years. The result is good. The difference is bailout stent because of the presence of dissections, and also the revascularization. And the bailout and the revascularization, it's not that high. It's 10%. It's 7 to 8 even percent, up to 9.4%. It's not that prohibitive, as encouraging so far. And also in the subgroups of patients, like the renal patients, with they may also gain some advantageous safety in this group of patients. The other registry for the osteal circumflex is a challenging anatomy, is difficult even for stenting. the difficulty even for the lesion preparation, for the rotablation, for the shockwave, because of the eccentricity of lesion and the bias in the symmetry of preparing the lesion. But the drug-coated balloon and drug-eluting stent, they do the close to each other. Diabetic patients with diffuse disease and also the acute coronary syndrome. So the rate of stenosis maybe is in diabetic patients is very high in general for drug-coated, for drug-eluting stents, and drug-eluting balloon or drug-coated balloon, it may offer some positive points in this one, since the healing and no residual metal or to irritate the vessel is there. In CTO is associated with dissections, intimal, subintimal tracts, and this may generate thrombus for stent. Yes, the thrombus is more with the can happen with both, but maybe the healing, physical healing, neoatherosclerosis is in favor of drug-coated balloon, especially in diffuse nature of the lesion. The other registry, which is recently also published over the last 2-3 years, is the evidence is growing very fast, and the sirolimus versus the drug-eluting stent, the durable long-term patency is expected. And in de novo in this registry, it was in 56% of patients de novo lesions. The rate of the incidence of the bailout stenting required in 7 to 8%. The target lesion revascularization at 2 years is 6.4. It's not high, so it's encouraging to support the drug-coated balloon in this field. The other trial which shows also the role of the drug-coated balloon, which is established in the guidelines for the ISR, and the evidence is stronger, and it came to the guidelines. And the elderly patients with high bleeding risk, also the DCB is favorable with significant result in terms of the bleeding. Preoperative intervention. Patients with a tumor in this study, they offer them the drug-coated balloon, so to minimize the dual antiplatelets, and also the clinical safety to have the patient underwent his surgery or her surgery safely. And recently presented in the TCT, sirolimus coated balloon in de novo lesion is a promising early safety and reduced lesion late lumen loss in this study. And the meta-analysis of multiple studies showed non-inferiority to the drug-eluting stent, and it's also is positive in this field. The limitations of the drug-coated balloon is the presence of dissections requiring bailout stent, and the need for optimal lesion preparation. This is reinforced by the different recommendations. Where the drug-coated balloon fits in the guidelines. In the guidelines is a class 1 for the ISR, it's well established, but there is a role which is not yet in the guidelines for the small diffuse disease, for the bleeding risk high, and the patients who required less dual antiplatelets. And thank you very much.
Thank you.